It's my pleasure to introduce Dr. Beth DeGrush, who's the Director of Neuropsychiatry Training and the Associate Director of the General Psychiatry Program, who will introduce today's speaker.
Okay, welcome everyone. It is my absolute pleasure to introduce Dr. Naillil Torres-Moreno this afternoon. To give you a little background on Dr. Torres-Moreno, she completed her bachelor's at the University of Puerto Rico and then attended medical school, also in Puerto Rico at the Ponce Medical School. Currently, she is our chief resident in geriatric psychiatry. And I'm delighted to announce, as she gave me permission, she will be continuing her training in Massachusetts at the Cambridge Health Alliance in geriatric psychiatry. This is wonderful news. And it all fits in with her presentation today. So many, if not all of you know, but I will tell those who don't, her warm and welcoming and compassionate personality is a perfect match for this patient population. And it perfectly complements, it's complemented by her excellent clinical acumen, her interest in consultation work, and the integration of medicine and psychiatry, because as we well know, these cases are medically complicated, emotionally complicated, and socially complicated. And Dr. Torres-Moreno does not back down from something like this. This topic today is of utmost importance, and I'm reminded of this almost every day in my own clinical practice. I look forward to hearing her speak today, so let's welcome her. Okay, thank you for that. Yeah, it's official news. I sent my email yesterday. Okay, so yes, Naillil, I'm a PGY4. The topic for my grand rounds is going to be isolated minds, the impact of loneliness on elderly mental health. A topic that's very dear to my heart, and we'll learn why as we go. No actual potential conflicts of interest in relation to this presentation. So let's talk about objectives. I am hoping that we gain understanding of the growing demographic of older adults, explore the concepts of loneliness and social isolation, examine their impacts on mental and physical health, discuss strategies of addressing these issues in clinical practice, and then explore some community resources available. I would like to start by talking about the population. So US older population continues to grow, as we know. Based on the last US Census in 2020, the population aged 65 and over grew nearly 5 times faster than the total population over 100 years from 1920 to 2020. In 2020, about 1 in 6 people in the United States were aged 65 and older, and compared to 1920, which the proportion was less than 1 in 20. From 2010 to 2020, the 65 plus population grew, had its largest 10-year ever numeric gain, and we might wonder what contributed to this demographic shift. So, not that we're pointing any fingers, but the rapid growth was largely driven by aging baby boomers. They were born from 1946 to 1964, and they began turning 65 in 2011. And if you think this is impressive, we're still not the oldest out there. So despite this growth, the US remains relatively young compared to many peer nations, with 16.8% of the population being 65 and older. I wanted to highlight how far up Puerto Rico is, with 22.3% of the population aging 65 and over. So I guess it's good that I'm doing a geriatric psychiatry fellowship. So this growing trend is expected to continue, highlighting the importance and the need to address this unique health challenge faced by older adults. Now that we get a sense of our demographic and what's going on with our older folks, I want to introduce my topic. So it is important to first recognize loneliness and social isolation are 2 well-distinguished concepts, as well as their relationship. So we will be continuing discussing that further along. Loneliness is a significant concern among the elderly, particularly in societies with rapid growth of aging population, as we just talked about United States. This topic is relevant to the physical, mental health, and longevity of older adults because circumstances of aging, such as relationship losses, medical comorbidities, and functional declines, are predisposing factors. Meta-analysis have found that social isolation or loneliness in older adults is associated with 50% increased risk of developing dementia, 30% increased risk of incidence of coronary artery disease or stroke, and 26% increase in all-cause mortality. Also, higher rates of clinical significant depression, anxiety, and suicidal ideation. I will ask you to please direct your attention to the picture that's presented. Based on the last census, there's a big portion of older adults living alone, highlighted in blue, making this a very significant issue. And I am sure that most of the people that we see in our clinic or in our geriatric clinic are part of that population, patients that are living alone at their homes. According to the National Health and Aging Trend Study in the United States, approximately 24% of the community dwelling older adults reported to feeling socially isolated, and 4% of them were severely socially isolated. This issue rapidly became so significant that the importance of social connections, the quantity, quality, and benefits of human relationships became a major focus of the empirical research in social determinants of health. Therefore, it is important to mention that being socially connected in a variety of ways is associated with having up to a 50% greater likelihood of survival. Let's talk concepts. So as I mentioned earlier, loneliness and social isolation are two distinct concepts with bidirectional relationship. So loneliness is the subjective distress feeling of being alone or separated, has been conceptualized as an imbalance between desired social contacts and actual social contacts. While social isolation is the objective lack or limited extent of social contact with others. In 2023, a national poll reported that about 37% of older US adults experienced loneliness, but only 34% reported being socially isolated, meaning that it's possible to feel lonely while among other peoples and vice versa. Being alone does not always imply the negative experience of loneliness. John T. Cacioppo was widely considered a pioneer in the study of loneliness, particularly due to his work in the Center for Cognitive and Social Neurosciences at University of Chicago, where he developed the evolutionary theory of loneliness and explored his biological impacts on the human body. The most established theoretical explanation of loneliness is his evolutionary theory of loneliness, which posits that loneliness initiates a highly conserved biological response that, while adaptive in the short term, when faced with lack of social contacts, is physically and psychological maladaptive in the long term, hence making this very important topic to explore for healthcare providers. In terms of risk factors and predictors factors for loneliness and social isolation, there are numerous, and some of them can be modifiable. They can also be at the individual level or at the community level, and they can be bidirectional and not mutually exclusive. For example, at the individual level, psychiatric conditions such as depression and anxiety can lead to social withdrawal and loneliness, and vice versa. Let's look at the image for a second, because I found this image very helpful. So individual level, including chronic conditions, sensory impairments, which we know at this population is very relevant, limited resources, trauma or trauma history, likelihood to live alone, increased frailty, loss of spouse and partners, outliving friends, loss of employment and caregiver roles are some of the predictors and risk factors that we see at the individual level. At the community level, so lack of employment and volunteer opportunities, stigma, ageism, discrimination, lack of transportation options, and lack of an age-friendly, livable community. Personally, this image was impactful for me. It helped me look at the community level and take that more into consideration. At times, I tend to be so focused on my patient, the medication regimen, if they tolerated the medication that I started or not, if we're gonna be able to cover everything in 30 minutes, well, taking them to the office already took me 8 minutes. And then that I tend to overlook the external factors. Being a part of a community that is not conducive of social interaction and that lacks resources will play a major role in predisposing our patients, specifically our geriatric patients, to the effects of loneliness and social isolation. Also important to note at the level of society as a whole, changes such as increased life expectancy, smaller family sizes, and geographic dispersion of families contributes to this growing issue. Loneliness was declared as a global epidemic by U.S. Surgeon General Vivek Murthy, who reported to occur approximately in 1/3 or more of older adults. Recent US-based research suggests that the range is 17% to 57% people experiencing loneliness regardless of age, but that number increases for those who have mental and physical health, particularly those with heart disease, depression, anxiety, and dementia. And if you think about it, our geriatric patients will meet all those criteria, or if not some, making them a particularly vulnerable population. Areas of the older adult life that can be negatively affected when individuals are experiencing loneliness and social isolation includes quality of life, cognition, physical and mental health, functionality, and need for healthcare services. I wanted to show one more slide with numbers, but I promise it will go down. In January of 2023, the University of Michigan conducted a national poll on healthy aging. They asked a national sample of US older adults questions related their loneliness and their social interactions. Particularly to note are the high rates of measured of loneliness in 2023 among older adults with fair or poor physical health and mental health. In fact, measures of loneliness among those with fair or poor mental health were slightly higher in 2023 compared with the early months of the pandemic in 2020, highlighting how relevant and important it is to address this issue that clearly has persisted. And if you look at the numbers, they are pretty significant numbers. Hopefully by now, I've convinced you guys that there's enough data indicating that this is a relevant issue impacting a growing population. So let's talk about those impacts. Okay, so health risk. Social isolation has been associated with a significant increase of premature mortality from all causes based on research spanning over 40 years. The increased risk is compared to the mortality impact we see with daily smoking and with obesity. There was a comprehensive meta-analysis conducted of 148 prospective studies that measured both social isolation and loneliness, as well as compared multifaceted measures of social connection over an average period of 7.5 years. Participants without strong social connection experienced 50% greater odds of mortality. Social isolation and loneliness has been found to increase the risk of developing coronary artery disease and stroke, independent of traditional cardiovascular disease risk in numerous longitudinal studies. It has also been associated with an increased risk of tobacco, alcohol, and substance abuse, increasing the risk for health comorbidities. Low social connectedness have been associated with higher healthcare utilization and worse prognosis for patients with cardiac disease, as well as high rates of metabolic syndromes. And if we think about our medications and we're thinking about metabolic syndrome, that should highlight that too. Vascular pathology and morbidity associated with social isolation and loneliness are likely to contribute to the onset and disease course of other late life conditions, such as geriatric depression and neurocognitive disorders. There was a study of over 11,000 older US adults found that lower frequency of in-person social contacts was related to higher rates of depression over 2 years, and high levels of loneliness, a low frequency of interaction with families and friends, and low levels of participation in community-based groups increase the risk of cognitive decline and major neurocognitive impairments. I want to focus on the two most common psychiatric conditions in older adults. So let's look at loneliness and depression. Depression is the leading cause of disability worldwide and is a major contributor to the overall global burden of disease. It is also one of the most common geriatric psychiatric disorders and is a major risk factor for disability and mortality in elderly patients. Previous research suggests that loneliness and depression are associated and often co-occur, but loneliness and social withdrawal are not diagnostic criteria of depression. As I mentioned earlier, loneliness represents a risk factor for development of depression in old age, but it also acts as a predictor of depression, facilitating the occurrence of depressive symptoms, and a promoter since it plays a role in ongoing worsening depression and hinders remission. Social disconnection has been associated with stress, suicide ideation, and self-harm in older adults. In a study of over 60,000 older adults, increased loneliness was among the primary motivations for self-harm. It is important to highlight that because of the specific population we are discussing, age-related conditions such as cognitive impairment, impaired physical mobility, impairment in activities of daily living, financial difficulties, bereavement, living conditions, and personality traits can cause difficulties in maintaining relationships and may act as a potential covariates that moderate the association between loneliness and depression. Loneliness is not an irreversible aspect of getting old, so interventions should be impacted to prevent and treat the detrimental impacts of loneliness. And depression is not a normal part of aging, so we should be highlighting those issues. Loneliness and cognitive function. So high levels of loneliness and low social interaction increase the risk of cognitive decline and dementia. As we've already stated, social factors such as living alone and infrequent social contacts increases dementia risk by approximately 50%. Evidence suggests that potential biological mechanisms include prolonged activation of the HPA axis. There's evidence that chronic psychological stress and loneliness leads to high levels of cortisol. Prolonged levels of cortisol may cause cellular damage in the brain that is associated with altered cognitive function. It is directly related to the reduce of dendritic branching, abnormal synapse formation, and neuronal death in the hippocampus and frontal cortex, areas known for their role in memory and executive function. Inflammation is another biological mechanism through which stress and loneliness may impact cognitive function. Lonely individuals are highly reactive to stress, and prolonged and greater activation of glucocorticoids may dysregulate inflammatory responses. Because inflammation has been implicated in pathological processes involved in Alzheimer's disease and dementia, increased inflammation in lonely individuals may serve as a pathway for impaired cognitive function. In addition, there's evidence that among cognitively normal adults, increased perception of loneliness have been associated with higher levels of brain amyloid and regional accumulation of tau protein, linking loneliness with pathological changes of early Alzheimer's disease. Social interactions, on the other hand, are thought to enhance cognitive capacity through activating and maintenance of the efficiency of brain networks. In preparation for this presentation, I found this image. I'm sorry if it's blurry, but I thought it effectively synthesized the concept that we've discussed so far. The visual representation not only outlines a potential mechanism by which social connections influence morbidity and mortality, but also highlights the complex interplay of the various aspects of our patient's background that might predispose and lead to poor outcomes. So we're not only talking about social connections, risk factors, biopsychosocial models, and health impacts, we're making sure that we're always connecting all of those that may lead to poor outcomes. So let's take a second to condense everything. Why is this important? Addressing loneliness in the elderly is crucial for several reasons. As we have already established, loneliness is closely linked to a variety of physical health problems, significant impacts in mental health. These mental health challenges can further exacerbate physical health, creating a cycle of deteriorating health. Additionally, loneliness can severely diminish the quality of life of the older adult, leaving them feeling isolated and disconnected from their community, which can lead to a loss of purpose and decreased life satisfaction. Social connections are vital for providing emotional support and resilience, helping older adults cope with stress and the many life transitions. By addressing loneliness, we can improve their overall well-being, enhance their quality of life, and potentially extend their lifespan. Furthermore, fostering social connections can help maintain cognitive function and independence, allowing the older adult to continue contributing to their community and maintain a sense of belonging and purpose. For us, practicing psychiatrists, it is crucial to recognize the profound impact of social isolation and loneliness on mental health, which I'm hoping we're doing here today. By now, I'm also hoping some of you are thinking that we should be implementing tools or techniques to assess for social isolation and loneliness among our patients, as these factors may contribute to and exacerbate clinical presentation, reduce treatment adherence, and increase healthcare utilization. So what can we do? First, let's talk about what to do at the level of patient-provider. There's this 4Ms framework proposed by the Age-Friendly Health System. This framework is intended to be used with every older adult during every interaction and across all settings, with the aim of ensuring older adults get the best care, are not harmed by the healthcare system, and are satisfied with their care, the care they received. The 4Ms we're going to be discussing. The first M is matters. So what matters? Exploring and assessing what it is important for the older adult in both their healthcare and their personal lives. Will help the treatment team align the care plan with the individual's goals and preferences. It is important to highlight that initiating goals of care conversation with the older adult and family caregivers will provide the opportunity of older adults to make their preferences known. The second M is for medication. Assessing medications include reviewing the medical necessity of all prescribed medications and identifying any high-risk medication. The third M stands for mentation. So preventing, identifying, treating, and managing the big threes of geriatric psychiatry, delirium, dementia, and depression across all settings is going to be influential. And additionally, educating and preparing family caregivers for providing care. The last M is mobility. Assessing overall mobility and functional status is going to be key for our older population. At this point, you might be wondering how this relates to assessing loneliness. Well, let me encourage you to consider the bigger picture. We're trying to set the stage for well-rounded visits with our patients, hopefully promoting an environment where the patient and their family members feel comfortable expressing their needs and vulnerabilities, with the end goal of nurturing a strong therapeutic alliance that hopefully will enhance patients' receptivity to our recommendations, whether those involve referrals to other providers, therapy, senior centers, PTs and OTs, or even considering transitioning to higher levels of care. There was an interesting article published at Psychiatry Times in January 29 of this year, titled A Prescription for Loneliness, Mitigating Social Isolation and Loneliness in Older Adults. Healthcare providers, especially mental health professionals, are well positioned to detect and respond to social isolation and loneliness among older adults. They recommend incorporating standardized instruments like the UCLA Loneliness Scale into routine psychiatric and primary care visits can help identify at-risk individuals early. It can also help integrate these findings into personalized care plans, for example, prescribing social interventions alongside with medication management and psychotherapy. The focus of this article was what should the clinician do? And they also focused on possible technology-assisted treatment, exploring ideas like video conferencing in between nursing homes, daily conference lines for adults to call and not necessarily talk to a healthcare provider, and peer support via digital platforms, all with good evidence, but not enough evidence. So more research needs to be done. When we're talking about measurements and things that we can incorporate in our daily visits, there's a variety of measurement scales that have been developed to assess social isolation and loneliness. Most of those scales are self-reported questionnaires that have been designed and implemented for research purposes. Important to note, the revised UCLA loneliness scale is a validated 20-item questionnaire that is a standard scale for measuring perceived loneliness. But to our luck, there is an abbreviated version of this questionnaire. The 3-item UCLA loneliness scale is widely used in research studies and for clinical identification of lonely older adults, probably the easiest one that we can implement in our practices. When you look at the scale, it's basically asking perceived loneliness. How often do you feel you lack companionship? How often do you feel left out? How often do you feel isolated from others? The higher the score, the higher the probability of this patient experiencing greater loneliness. The other one that's projected is the Steptoe Social Isolation Index. It's a 5-item scale with 1 point being assigned for each of the following: being unmarried or not cohabitating, less than monthly contact with children, less than monthly contact with other family, less than monthly contact with friends, and no participation in social clubs, resident groups, religious groups, or committees. A higher score also indicating high predisposition to social isolation. Important to know that this is not diagnostic, but can give us a sense of the patient that we are assessing and what recommendations we can add to help our patient deal with the feelings of loneliness and maybe help them deal with social isolation. What are the recommended interventions with good evidence? So currently, nearly all interventions that have been proposed to treat isolation and loneliness are behavioral or psychological in nature. However, the interventions that focus only on increasing the time spent socializing or increasing the number of social contacts may be greatly impacted by underlying symptoms like anxiety, fear, depression. Medications should be implemented in attempts to treat and minimize some of those negative behavioral effects of social isolation and loneliness, hence hoping that we can enhance the effects of the actual social interventions. Individual therapy can be effective. There's strong evidence supporting CBT models. It is a well-established therapeutic approach that can help older adults address negative thought patterns contributing to loneliness. A study published in the American Journal of Geriatric Psychiatry found that CBT effectively reduced loneliness and depressive symptoms by helping them develop healthier coping strategies and thought patterns. The second one with the most evidence, mindfulness-based therapy, which proposed that can help older adults become more present and engaged when they're attempting to interact socially, reducing feelings of loneliness. The third one is interpersonal therapy, focusing on improving interpersonal relationships and social functioning, which can be particularly beneficial for lonely older adults. Reminiscent therapy is the fourth one. This therapy involves discussing past experiences and memories, which can enhance social connectedness and increase their sense of belonging. That one being the one with more scarce evidence. The other things that we can recommend that I very often do in my geriatric clinic are the things that are on the right of the slide. So we should be encouraging our patient to focus on self-care, even if that includes referring them back to their PCP to consider PCA services, VNA services, or home maintenance services. So being that connector in between the patient and their home. Pursuing interest, physical activity as tolerated. Sometimes that might look like referring them to PT. Staying connected with family, friends, or neighbors. Volunteering opportunities if allowed. Pet caring. Incorporating technology and community engagements. Introducing them to the ideas of interacting in their neighborhoods, joining to local clubs, senior centers, community centers, adult day programs, and libraries are ways to encourage community engagement to our patients. I am aware that to incorporate all of those recommendations, the patient needs to be at a certain functionality at a symptom for functionality status. So we'll talk about what to do when patients are like more decompensated. I wanted to make a note about the term social prescribing. So social prescribing is a fairly new concept or model. It's means for healthcare providers to connect patients to a range of non-clinical supports and services in the community to improve health and well-being and to strengthen their community connections. The exact social prescriptions are specific to each community and care setting and vary depending on the needs for the patient. The image that's projected is the World Health. So the World Health Organization created a toolkit to help introduce social prescribing in the community level. In the most common model, the primary healthcare provider or the mental health provider can refer patients to the specialized link worker, who with the patient will identify their social needs. The link worker would typically work with community providers and design a specialized plan for the patient to be integrated in the community. The link work model can be adapted to each unique context. For example, a link worker could be an existing staff member, such as a social worker, nurse, a case manager, care coordinator, or it can also be a community worker, an external organization, or a newly created position. Social prescribing has been implemented in several countries, including Australia, Canada, Ireland, Japan, Portugal, and Singapore. There are initiatives in the United States, but it's not implemented yet. Social prescribing is relatively new in the healthcare system, as it requires inclusion of community partners from outside the healthcare sector. Evidence is still mixed, and while positive outcomes have been found at an individual level, with studies indicating that social prescribing may be effective in improving health and well-being, there has also been inconsistent outcomes indicating variability in effectiveness. The limitations for these models include challenges in implementation. It requires coordination and collaboration between healthcare providers and community resources, which can be challenging to establish and maintain. There may be barriers such as funding, training, and infrastructure. The second limitation has been lack of standardization. The lack of a standardized protocol and measures for evaluating the effectiveness of social prescribing can make it difficult to assess its true impact. And the third limitation has been limited research. While promising, the evidence base for social prescribing is still developing. More high-quality, large-scale studies are needed to better understand its benefits and its limitation across different populations and settings. So as I mentioned earlier, what to do with patients that might be a little bit more compromised or cognitively impaired. Considering transitioning to higher levels of care is a conversation that we have very often in the geriatric clinic. It's a risk versus benefit conversation, and we attempt to include family members and caregivers as possible. Consider patients' medical needs, functional abilities, and safety concerns. And it might not always be beneficial, but sometimes it's needed. There's the different levels of senior care, which I'm not gonna go into, but I do wanna talk about the evidence. So evidence suggests that long-term care facilities can help reduce loneliness among the elderly through the effectiveness, though the effectiveness can vary based on several factors such as quality of the facility, level of social interaction provided, and the individual's personal preferences and social needs. Key findings from research. Many long-term care facilities offer structured social activities, group outings, and communal dining that can foster social connections and help reduce feelings of isolation. They provide supportive environment, and some facilities provide access to mental health professionals who can help address feelings of loneliness and depression, offering counseling, medication, and supports. Also, facilities that prioritize resident-centered care, encourage family involvement, and maintain a positive atmosphere tends to be better for the outcomes of reducing loneliness. Challenges and considerations when thinking about transitioning to higher levels of care. The initial transition to a long-term care facility can be challenging for some individuals, potentially increasing the feeling of loneliness until they adapt to their new environment. Personal preference is also something that we should consider, and it poses a challenge when transitioning. Some elderly individuals, many, may prefer staying at their own homes with home-based care services, finding that arrangement more conducive to maintain their social networks and sense of ownership. I want to make a moment or like a second to share my personal experience. So my family is composed of my mom, my grandfather, and myself. That's us out there. I was raised by my single mom, but by a single mother and my grandfather, who I affectionately called Dad. My grandfather endured numerous medical conditions throughout his life, including multiple strokes that progressively led to significant functional impairments. My mother served as his main caregiver, and as I grew older, I also took a caregiver responsibility. Over time, his health declined. He required more care and assistance with daily activities, including the occasional night scare run to the ER because he fell out of bed attempting to get out of to the bathroom without assistance. My mother and I managed these demands as best as we could, but as I approached my final year of college and prepared to move away from home for medical school, we faced a difficult discussion of if transitioning my grandfather to a higher level of care was needed. Fortunately, he did not suffer from any cognitive disorders, allowing him to actively participate in the decision-making process. Together, we selected a nursing home conveniently located just one street away from my home. This proximity enabled my mom to visit him daily after work, and I joined her on weekends when I returned home from medical school. We were fortunate to find a facility with exceptional staff who genuinely care for their residents. The nursing home provided a range of social activities, outings, celebrations of every holiday and birthdays, ensuring a supportive environment where my grandfather's needs were met comprehensively. This transition proved to be the right decision for our family. I witnessed firsthand the positive impact it had on my grandfather's quality of life, my mother's well-being as the primary caregiver, and my peace of mind knowing that my mother was no longer solely responsible for his care while I was an hour and 20 minutes away from home, a distance that now seems so minor compared to a 4-hour flight. As you can see in the pictures, they were engaging in many activities. I covered the other residents' faces just for confidentiality, but it was truly an impact to my family and to my grandfather, and he got to spend his last 3 years there. Let's just touch on resources in the community. Projector are some of the ones that I was able to find. I wanted to find resources that allowed for specific region search. So Elder Care Locator and Massachusetts Care Planning Council allowed you to put the patient's zip code and provide a list of resources available in the community, ranging from providers, social settings, adult day programs, senior centers, clubhouses. NAMI and mass.gov have a whole page for older adults resources. And very often in the Jerry Clinic, we utilize the Alzheimer's Association. Alzheimer's Associations allows you to make specific referrals for patients and their caregivers, having them connected with resources and options in the community. Then I also found the Massachusetts Clubhouse Coalition, which I didn't know existed, but they offer a list by region in the state of all the available clubhouses available for patients with mental health disorders. And I'm sure these are only some of them, but I think these are the ones that I've used the most. I wanted to end giving special thanks to my mentors and supervisors for their guidance and providing time and space to nurture curiosity, especially Dr. Richler, program directors, and Linda. I am grateful for the opportunity to participate in grant rounds And for the support, my co-residents. Also for the support and always believing in my abilities, and my mom, who's been the main motivation and the reason I pursued medicine in the first place. Her strength and encouragement continue to inspire me every day. And then I wanted to end. So Dr. Padilla shared with me a podcast that was very interesting, and I wanted to end with a quote that the Surgeon General Vivek Murthy said on the podcast. So it's our connection to each other, but also our commitment to one another and the society that can often be the greatest source of fulfillment and joy. So that's it. Reference that.
Questions?
Great presentation, Naillil. Question about group therapy for older adults. Have you read a lot of evidence or literature about group therapy? Do you personally recommend group therapy? Just wanted your thoughts.
Yeah. So in all my research, so I should have mentioned that. So therapy-based models, group therapy was better than individual therapy for older adults. So the evidence is better for group-based, but there's not a lot of evidence in which specific types besides like interpersonal, just like therapy but group therapy was better than individual. And then group therapies that include the reminiscing model. So basically them sitting around kind of like talking about memories, their experiences, the contributions to the community. That was the thing that had better evidence to improve their sense of loneliness, just because, again, I feel it improved their sense of belonging and community. But yeah, group-based better than individual-based therapy.
Thank you.
Yeah.
Hi.
Hi.
Thank you so much for that presentation, and thanks for sharing your grandfather and that story with us. One of the challenges that I came across a lot in Jerry Psych was patients' ambivalence about going to community centers or senior centers and them just not wanting to do that. How do you usually manage that and kind of increasing motivation or their curiosity to actually check out those resources?
Yeah. Same. It happens to me all the time, and I always go to Dr. Rich and I'm like, I keep hitting the same wall. I've had better outcomes when I incorporate the family and I try to make it more like a group decision. But I've also sat down with my and I know this is like very time, like there's not always a lot of time, but I've also sat down with my patient and explored the resources with them. Most of my patients are just scared of what they might find when they get there. So just explaining that it's gonna be a lot of other older people just engaging in activities, and it's gonna be in a supportive setting has helped. But the best way has been incorporating the families, or at least the caregivers, someone that they feel connected to that might give them that sense of this is gonna be fine. Also incorporating the PCP. Like PCPs has been my like right hand side, like in a geriatric clinic. Fortunately, I've bumped into very like caring PCPs that are welcoming of all the recommendations. So PCPs have also been a crucial part of it. And it's funny because when they come back, they're like, you talked to my PCP, right? And I'm like, yes, I did. So that has also been an important thing. Yeah.
So thanks very much for bringing the subject up. It's important to bring this up. So in the younger part of the United States, there's been a lot of thought that their involvement more and more in an online world and less with their friends in the community might be doing some long-term damage to that generation, right? Some baby boomers, I can vouch for this, are actually computer literate and internet natives. But I am not certain about the role of encouraging or discouraging online life for people who are facing loneliness when it's true they might make friends and have some sort of communication, but they also might just spend hours lost in scrolling and become more desperate and lonely. So has there been some thought about, and I want to put, we had a Brain Bee winner several years ago who developed an app for kids to work on with their grandparents who have dementia. It was a game they could play together that was one of that you could only play it with a family member. That was one of those things that was aimed at like practicing, kind of your cognitive skills and everything. But you had, there were points and you play against your grandchildren. And it was really cute. So, I mean, that would be a way I would think of bridging the dangers of it. But what do you think about that? Is there evidence, whatever?
It's interesting because the podcast that Dr. Perias chaired, so they did talked about that, and he did mention that from where you're coming from. So he was talking a little bit about the younger population. So he's saying like, trends have been that it's detrimental, kind of like the doom scrolling and just staying hours and hours. And actually he made a comment about when he engages with older adults, and like in their deathbeds, what they're saying is, they're talking about actual interactions with people. No one's talking about Facebook friends, Instagram. And so he was making a comment about that. When I was doing for this presentation, there's a lot of articles and research that's starting recently about like incorporating technology in the older population, but it's just been such a big challenge to have them utilize the things that the evidence is not good. But I did see good evidence in the one that I mentioned earlier, that was having like the group, like the study was like having nursing homes and have like a carved out hour where they're doing like Zoom group therapy kind of thing that had good evidence. And it was very positive for the nursing homes, but it wasn't in the United States.
Are you still going to be posting on social media when you're 85?
Well, I don't know. Maybe for UMass. Because I run the Instagram. But no, it was interesting because I did hear in the podcast and they were saying how detrimental it has been for the younger population. So, yeah.
Okay, we have a couple of questions online. Dr. Goodness says, wonderful presentation and resources. Thank you. Is there a way to connect to you or other providers if we have patients who would benefit from meeting with a Jerry Psych clinician?
Good question. Yeah, refer them to the clinic. Me and Dr. Richler are the first barriers. We get all the referrals and we usually accept them. So the UMass behavioral order. Our clinic is, well, Dr. Richard joined us, what was it, 2 years ago already? 3 years? Yeah. And the clinic has just been up. Right now we are getting so many patients and the waiting list is pretty long. But we do our best with the residents and it's a very good, amazing experience. So yeah, referring them to our clinic.
So Dr. Rickler has appeared online.
Oh God.
And she says, thank you so much for this. Socializing with you is probably some of the best care your patients get. Can you comment on PACE, P-A-C-E, as a resource as well?
Oh God, Dr. Richler. Yeah, so PACE is a clinic that I don't know a lot of information about, but I know Gilly did it. So no, sorry, Dr. Richard, I can't. But I know it exists.
Dr. Chopra makes a comment that joining attending a senior center generally goes well. The more difficult transition is when one partner has to move to a memory care or assisted living facility.
Yeah, and it's interesting that comment because I have a couple in the geriatric clinic, a lady with severe dementia, and the husband, a lot of medical disorders or diseases, but he's cognitively, we'll say, intact. And they live alone, and it's not great. So me and Dr. Richard, we've been trying our best, connecting with the PCP, connecting with their daughter, but they won't want to move, and they don't want to move. And when we discussed about sending her to the memory unit and him, that was just like the biggest conversation, and they were very upset with me. So yes, I see that all the time, and it's very difficult when we're talking about separating a couple or just based on needs, because again, she is very cognitively impaired. So that's very difficult.
Dr. Breslin asks, says, great presentation. Do aging individuals with serious mental illness pose special challenges?
Come again? Sorry.
Do aging individuals with serious mental illness pose special challenges?
Like in general? Well, that's a good question. I don't necessarily have an answer. I guess when I'm treating them in the outpatient community, it might just limit the resources that we can offer. It might limit the recommendations, but other than that, I don't have a lot of experience inpatient. But yeah, great question. I don't necessarily know. Oh my God.
Well, we could take this.
You're like halfway already.
I like asking about this because I really like my grandparents, so it's a good topic. About cultural kind of beliefs, like individualized cultures versus like communal cultures. Do you see any differences in how they engage in these types of resources? For example, if some are more communal and they are more family-based, are they less likely to engage in like individual type resources?
That's a good question. And I think PR is very communal, and we tend to like die in our homes, and everyone dies in the same home. So yes, there's evidence that they engage less. And again, I mentioned a little bit about, so those are the types of patients that are gonna prefer the home-based care services rather than moving out to like a long-term care facility or engaging on like anything outside of home. So I think the answer is yes, depending on culture and like the community, you're gonna see the trends. And I think when we were talking about risk factors and the community level, that's what I was trying to hint at. Like if you have a community that's not conducive of like engaging socially, then that's gonna pose a higher risk factor than if you have a community that just tends to go out and to the community center. When we're thinking about higher levels of care, I also try to tell that to my patients, like you're gonna be in a community that does the same thing they all go to the dining room. And so then I post that way as well. But yes, community and culture is gonna be a big factor. Yeah.
Dr. Wickler makes a comment. We try to remind folks that socialization is some of the best ways to exercise the brain and strengthen neural networks to improve cognitive functioning.
Yeah, and it's again, I'm gonna go back to the podcast because it was so interesting. The U.S. Surgeon General Vivek Murthy, he was saying that the social muscle got literally atrophied during the pandemic. So then it's not only about exercising that muscle, but then people forgot how to do that. So then coming back into the society and the community, and how do we talk to each other and how to maintain eye contact with each other. So he was commenting about that, the social muscle, and how it was significantly impacted. And then we're seeing it in the trends, right? Like it's 2023, 2024, and the number continues to go up instead of, going down because the pandemic is done. No. So yeah, great comment, Dr. Richler.
Any other questions? All right. Well, thank you very much. Very, very interesting presentation.